Okay, let's get started, and folks can join us when they can. So good morning, everyone. We're very excited for our global meeting this morning of the MIYCN-FP Immunization Integration Community of Practice. We have our global meetings about twice a year. And so this is our first global meeting of 2024. So we're very excited that you are with us this morning. Next slide, please. As a reminder, we have interpretation today. So we have French and Spanish interpretation, and you can join the interpretation channel of your choice at the bottom of the Zoom screen. Unfortunately, we only have one French interpreter today. So we're hoping to get a second at some point during the meeting to give her a break, but please be patient with our French interpreter since she will be doing the full hour and a half on her own. But we're very glad that she's with us today. So please feel free to use the interpretation channel. Next slide. Just a few reminders before we jump into this morning's technical presentation. We really recommend using a headset during the meeting to reduce background noise, and it helps with hearing the interpreters. We will use a Q&A chat box for the presentation itself, so you'll have the opportunity to ask questions after the presentation, but please use the Zoom chat throughout the meeting as a way to interact with each other. You can always sort of ask questions or let us know if you're having issues throughout the meeting. We will make sure that we try to answer all of your questions. If you're having technology issues, you can always direct message Anna Petricell or Shantae, and they can try to help fix the technology issues for you. This meeting is being recorded, and since we do have live interpretation in French and Spanish, please remember to speak slowly and clearly, which helps our interpreters. And we really want to see sort of who's joined us today. So if you can now, please share your name, your organization, and the country where you're joining us from now. And I will start by sharing that my name is Lindsay Miller. I'm the technical manager for family planning on the Momentum Country and Global Leadership Project at JPIGO. And I am joined by many colleagues here who help lead the steering committee of our community of practice. Next slide, please. So here's the agenda for today's meeting. We are going to start with a technical presentation from our colleague, Dr. Chizoba, who is the immunization director for USAID's Momentum Country and Global Leadership Project. After that, you'll have an opportunity to ask questions. And then we're going to jump into our breakout rooms. And this is where we're going to spend most of our meeting today. We really strive to make these meetings interactive. We try to make them, as much two-way communication as possible. And so we'll have 6 breakout rooms, including 1 breakout room for Spanish speakers and 1 breakout room for French speakers. And we're going to discuss how can family planning services feasibly and effectively contribute to MIYCN and increase childhood vaccination rates, particularly during the preconception and postpartum period, and what can be done during antenatal care to increase childhood vaccination rates and postpartum family planning rates. And then at the end of the meeting, we're going to come back together, and we're excited to share with you a few new ways that we're able to connect as a community. Next slide, please. Great. So now I'm going to hand it off to Dr. Chizoba to lead us through our technical presentation. Chizoba, over to you.
Thank you, Lindsay. Good morning, good afternoon, everyone, depending on where you're joining from. It's my pleasure today to present a study set of activities that we've been doing. It's a collaboration between the immunization program of MCGL and the nutrition program. So today we're going to be looking at the relationship between zero-dose children and wasting and examining the promise of integrated service delivery. Next slide. So just to acknowledge that this is teamwork. These are the authors in the presentation. We have folks from IVAC at Hawkins, Save the Children, and our USAID and our colleagues in Madagascar and Jepaigo. Next slide. So as a background, zero-dose children are those children who have not received any vaccination from the routine immunization program. The latest data from WHO and UNICEF show that as at 2021, there were 18.2 million zero-dose children, and that translates to 1 in 7 children globally being zero-dose. In Madagascar, which is one of the top 20 priority countries for the big catch-up, these are countries that have a high burden of zero-dose children that WHO has prioritized. In Madagascar, there are more than 462,000 zero-dose children, and that translates to 1 in 3 children being zero-dose. So the reason zero-dose children are important is that they have been identified as a marker of inequity in access to healthcare, and a marker of inequity to basically several developmental milestones or developmental indices. And particularly, we're concerned about zero-dose and wasting because we know there is this unholy alliance between malnutrition and on immunization. Malnourished children are very prone to infections, and unvaccinated children are also highly prone to infections. So there is a potentiation of effect across the two vulnerabilities. So what we did at USAID was to work with between the immunization and the nutrition team to put together some evidence that will guide better efforts to address both zero-dose and malnutrition, given that Madagascar had a high prevalence of both zero-dose and wasting. Next slide. So our study objectives, broadly speaking, was first of all to understand better who these zero-dose children are and children who are wasting. So to do that, we described the prevalence of zero-dose and wasting as separate outcomes and then as joint outcomes. So looking at that intersection of risk between kids who are zero-dose and are also wasted. We described where they are distributed geographically, and then we also looked at their social demographic profiles in order to better understand and characterize them. Then we looked at the programmatic challenges of integrating nutrition services. So it's a mixed methods study that's using analytic methods as well as health systems analysis to come to some recommendations for the immunization program. Next slide. So I'll just breeze through this to tell you that in terms of the data that we use to describe the zero-dose children, we use the Madagascar DHIS survey that was published in 2021. And we looked at children 12 to 35 months of age because those are the kids who have immunization data in it. Then the outcome that we use for zero-dose is non-receipt of BCG, polio, DPT, and MCV. Practically speaking, in the immunization community, zero-dose is defined as kids who have not received DPT-1. But because we have survey data and we had the luxury of identifying vaccine receipts by antigen, we're able to give a more purist definition of zero dose, which is kids who have not received any of the vaccines at all. So for wasting, we use the standard definition of wasting, which is greater than 2 standard deviation below the average weight for height. And then for the combined outcome, what we did was any kid that met both the zero dose definition and wasting definition that was defined as both zero dose and wasted. So for predictors, we looked at demographic, maternal, healthcare access, media access, and then female autonomy. These are all factors noted in the literature as being associated with either outcomes. Next slide. And for the analysis we did, we looked at prevalence, we looked at regional differences, we used both bivariate and multivariate analysis to look at the association of household demographic factors with the outcomes. And then for the objective 4, we described the challenges and solutions to immunization and nutrition integration in the country. Next slide. The 4th objective, which is to understand the challenges with immunization and nutrition integration, we did human-centered design workshops with both national and regional stakeholders, as well as with, we worked with EPI managers, WHO, UNICEF, vaccinators, community leaders, and caregivers. It was a one-day workshop in Antananarivo, and participants were able to discuss what they considered the barriers to integration of immunization and nutrition services and what solutions to put forward. Next slide. So here are the results. So for the first question of what proportion of children in Madagascar are zero dose or have both outcomes, here is what we saw. Next slide. So what we see here is that 18%, almost 19% of children in Madagascar, that's 12 to 35 months of age, were zero dose. So that's 2 times the proportion that were wasted. This means that 1 in 4 children were either zero dose or wasted. Now, thinking about the most vulnerable group, those with the combined outcome of both zero dose and wasting, luckily, there were only 2.2% that was both zero dose and wasted. Next slide. Advance, please. Advance again. Right. So here is a depiction of what I just said. And it's important to note that while wasting was 9%, we found that stunting was even occurring at a higher prevalence, which is almost 44% of kids were stunted. But we're focusing on wasting because that's an acute condition that can be amenable to interventions. Next slide. So what regions had the highest prevalence of both outcomes? Next slide. You see, what you see here is we've mapped both zero dose wasting and then combined outcome as well as one or the other. So is a kid in a region, what proportion are either zero dose or wasted? It's interesting to note that in Ihirombe, as much as almost 45% of the kids are either zero dose or wasted. So nearly half of the kids have one of these 2 outcomes. And when you look geographically, Madagascar is an island nation. It was curious to us to see that along the perimeter of the island, along the western perimeter of the island, as well as the southern perimeter, you see that the regions there are the ones with the highest prevalence of either outcome. So these regions have more than 33% of either zero dose or wasted children. The next thing we then do is, next slide, We then said, okay, if you were to prioritize, how would you do that? So we divided the regions into 4 typologies. So where you have high wasting, high zero dose, and where you have low wasting, low zero dose. So if you were to prioritize the regions where you would do your integrated intervention, assuming limited resources, where would you focus? So what we ended up seeing is 4 typologies in the top left quadrant that is numbered 1. So these are regions with high zero dose and low wasting. Then top right with the brown quadrant, number 2, these are your top priorities where you have high wasting and high zero dose. So this was done to support prioritization effort in the country. Next slide. Another way to look at this data is to ask, where are the number of children that are zero dose or wasted concentrated? So we're looking at we were looking at proportion here. Now we're looking at absolute numbers, and we're looking at how are these zero dose children distributed? So what we see here at the top is the kids who are zero dose and wasted. The middle line is wasted, and the bottom line is just zero dose. You see that when you consider all the kids who are both zero dose and wasted, the majority of them, nearly half of those children, are found in only 4 regions. So Sava, Android, and the other two regions mentioned there. So if you wanted to really pinpoint where the most vulnerable kids are, those are the regions that you'll be looking at. Next slide. So what is the profile of these children, these zero dose and wasted children? Next slide. What we did here is to look at the bivariate relationship between zero dose and some of the demographic characteristics I mentioned earlier. So on the left-hand figure, look at the dark green bar. You see that when you compare the general population, so the bottom bar in the left-hand figure, when you compare the dark green bar, you see that it's much shorter than the top bar in the top bar of zero dose and malnourished children. So this is looking at the proportion of children who are zero dose and their mother's education. So while in the general population, you have only about 21% of their moms having no education, when you look at kids who have both outcomes of zero dose and wasting, nearly 50% of their moms have no education. So there is a very strong relationship, even a dose-response relationship between zero dose and wasting, as well as zero dose and wasting and the joint outcome. The same thing with wealth quintile. You see that the kids who have both outcomes have come from the poorest, majority of a high proportion of them come from the poorest quintile. When it comes to where they live in terms of residence, there's really no such, you don't see a clear relationship between urban and rural residents. So you have pretty much equal distribution of all outcomes across both the rural and then urban areas. Next slide. Again, we looked at maternal factors. Maternal factors, where it also relates to access to care, right? On the left-hand side, you see antenatal visits. Again, you find that kids who have both outcomes, their moms, a high proportion of their moms had 0 antenatal clinic. So that's 35% compared to 11% amongst kids in the general population. You look at tetanus vaccination, you also find that kids who have both outcomes, kids who are 0 dose, have moms who had no tetanus vaccination during their pregnancy. The same pattern is showing up for place of delivery. General population, 61% of the kids were delivered in a facility. Among 0 dose and wasted children, you see that 81% of them were delivered outside a health facility. Sorry. Okay, well, sorry, pardon me, the label was blocked. 61% of children generally were delivered at home. When you look at kids with both outcomes, is 81%. So there is a stark association between these outcomes and poor access to care. And that is actually reflected strongly for 0 dose. Next slide. Okay, so vitamin A we know is one of the nutritional supplements. We look to see the relationship between access or receipt of vitamin A and wasting, 0 dose, and both outcomes. So on the right-hand side, you see the figure that shows that in the overall population, about 39% of the kids had received vitamin A in the past 6 months. Then this was nearly followed by wasted children with wasting, where it was 34%. And then a smaller proportion of the 0 dose children had received vitamin A than the proportion of wasted children who had received that service as well. So what we are seeing here is that 0 dose is actually more strongly associated with access to services, whether it is, maternal services or this vitamin A service. Next slide. So we then put everything into multivariate model. We had a separate model for 0 dose and a separate model for wasting to try to find out those associations that remain significant in, when you control for the other covariates. So we ended up seeing that, first of all, a greater number of factors were correlated with 0 dose status, right? And for the demographic correlations, wealth quintile remained significant. For maternal factors, for both 0 dose and wasting, maternal education remained significant. And then for wasting, maternal age remained significant. So that meant that adolescent moms were more likely to have wasted children. Then for healthcare access, we saw that 0 dose again, we saw the significant association of ANC visits or lack of ANC visits, not having tetanus injections, and not delivering in health facilities. So for media access, we also found that the lower the frequency of listening to radio, the higher the risk of 0 dose, and similar thing for television and wasting. So we see that the 0 dose children have a slightly different profile from the children that are wasted when you look at the outcomes separately, where with more variables associated with 0 dose. Next slide. Okay, so now we've identified the burden of 0 dose, the concentration of 0 dose. We've seen where they are located geographically, and we've also looked at their profile and seen what are the associated characteristics with the 0 dose children. We now go into what we found from the HCD workshops, where we try to understand what the current status of integration is and what the key barriers are. So we found from the workshop that integration of immunization and nutrition services were happening, but only in a few facilities. And services that were integrated were vitamin A supplementation, breastfeeding counseling, growth monitoring, referral for acute, for treatment of acute malnourishment. And then they also had monthly meetings between the immunization service providers and nutrition focal persons. And when we tried to figure out why there was this barrier to integration, because it's not for a lack of knowledge that integration is not happening. It's just that we know that integration is good, but are we making the right investments to make sure that it happens? So some of the key barriers are that, you know, the unavailability of health workers, that's the biggest challenge that they have there. And then there were also mentioned a lack of policies or guidelines that will, you know, provide guidance for integration to happen at the different levels. And then sometimes we have inadequate equipment and infrastructure for the service delivery. Next slide. So what were the recommended actions? One, to improve coordination, monthly, quarterly joint meetings at all levels. So that way it can drive joint planning, joint delivery, use of resources, and all. Then map and leverage opportunities for partnership with existing food programs. And then because there was a lack of guidelines for detailed integration, they recommended we should develop a roadmap for integration of nutrition and immunization services. Then train health workers in all health facilities, provide nutritional supplements as incentives to caregivers for immunization, so that can be like demand creation, and then strengthen the demand creation for both services in the community through community leaders and engagement. Next slide. So having collected all that information, we then went on to now think about how to develop a more comprehensive model for integration that will address both outcomes. So what we came up with is, next slide. We looked at how can we improve planning, execution, and monitoring of integrated services so that we can optimize synergies, gains, and efficiencies. And our goal is to increase immunization access and uptake, and then enhance the provision of integrated services. Next slide. So what we did was to look at the health system's pillars, right? So we looked at planning and coordination, service delivery, supply, and logistics. What do we need to do at planning and coordination, in the planning and coordination pillar, across the national, regional, district, facility, and community levels to improve integration, to improve planning and coordination for integration? So I'm not going to go into details of this, but that's the approach we used for the model. A good example is to make sure that the nutrition people are talking to the immunization people and considering how integration can happen. We needed to have liaison persons that will attend the meetings of both program areas and ensure that while they are creating their annual plans or their semi-annual plans, that the considerations for integration for both programs are put into the plan development. So there are other mechanisms of integration that we're thinking about, such as having a joint calendar, having these joint planning meetings, and then also having joint monitoring and supervision of their activities. Then for the service delivery, what we've done is to visualize the different platforms for immunization, for nutrition, both at the facility and the community level. And for each touch point, each time a child is in contact with a healthcare provider, we have now mapped out what the immunization or nutrition service should be, and to make sure that that is clearly defined, and that will be included in some kind of job aids that will ensure that these services, as long as a nutrition person is seeing a kid, what are the immunization services they could provide, like vaccination screening and catch-up vaccinations for them. And the same thing for the immunization program. For supply and logistics, we're looking at the commodities that can fit in naturally into the supply chain of both immunization and nutrition programs. Next slide. Then the same thing for communication and demand generation. We're identifying the different, let's say, community platforms where nutrition, for example, does their demand generation. So, for example, they have peer-to-peer mothers group that talk about nutrition and give each other advice on nutrition. To what extent can we introduce immunization key messages in those conversations? And I already talked about supervision, having joint supervisory meetings, and then having monitoring, evaluation, and learning. So we have to define common metrics to measure our performance on integration, in addition to our performance on improving uptake of the services that are offered for both platforms. But we also need to define those integration models. And that is the only way we can ensure that we're keeping track and improving the integration agenda. Next slide. So to summarize, what we found is that in Madagascar, nearly 1 in 5 children are zero dose and nearly 1 in 10 children are wasted. And then when you look at the combined outcomes, 1 in 4 children are either zero dose or wasted. When you look at either outcomes, 1 in 4 children are either zero dose or wasted. Now, we saw that small group, that group that has both outcomes, that has the highest level of vulnerability, luckily is a small percent, which is 2.2, but that's a population that we really need to prioritize because they have such a high risk. And then we have 6 regions where we identify them to have high prevalence of zero dose and wasting. Next slide. So we also saw that factors associated with being zero dose were not necessarily mapped onto the same factors that predicted wasting, except for maternal education. So this highlights the importance of intersectoral collaboration. Maternal education has always been a risk factor for pretty much any child health poor outcome. To what extent are we reaching out to the educational sector to try and solve our problem by improving maternal education? So we need to go beyond just reporting maternal education as a risk factor and think about how we can be intentional about intersectoral collaboration and integration. So again, the profile of the zero-dose child indicates more strongly access barriers compared to the profile of the wasted child. So when we integrate nutrition and immunization programs and potentially food security programs, we can strengthen access to care, and we can minimize the dual problem of poor access to care and to food. Next slide. So in conclusion, we have found very strong evidence that integrating immunization and nutrition services will serve a high proportion of children in need. We have also identified areas, geographic areas where these efforts can be concentrated if need be. And we have also looked at these suggestions from the immunization stakeholders on how to improve this integration, which suggests that we must take a systematic look at all the health systems pillars and then make sure that integration is happening at all levels so that we can have a comprehensive and more sustainable efforts at integration to deliver the services that these kids need to survive and thrive. Thank you very much. I think this should be my last slide.
Great. Thank you so much, Chizoba. That was a really interesting presentation, and many of the researchers have joined us today, many of your colleagues. And so it's really exciting that all of you will be in the breakout groups in just a minute, so can continue the discussion there. First, we have some time first just to say, well done on staying on time. We're right on time. So we have plenty of time for questions, if you don't mind. Habtamu has tried to address them in the chat as you were presenting, but there are a few more. Chizoba, if you don't mind, if we can start discussing. So the first is from Joseph. And Joseph says, I'm surprised there's so few respondents with data for both immunizations and nutrition. Is this generally the case with DHS data?
So for immunization, there was no restriction. So I think all the eligible children in the households that were surveyed received the questionnaire for immunization. For nutrition, it's a subset of the households, the DHS households, the households that were surveyed in the DHS that received the nutrition questionnaire. So when we want to look at the joint outcome, we now have a drop-off in the sample size. I believe that's the question you're asking, correct?
Thanks, Chizoba. So An had a question, and she says, one of the barriers was a lack of policy. Any interventions for this to eventually inform national policy?
Yeah, so that's what we're doing right now. So currently, in fact, maybe by tomorrow or so, our team is going to do a health facility assessment, a readiness assessment. So they are going to look at health facilities in 3 districts to understand their readiness for integration. So do they have the wherewithal to integrate? Do they have the personnel? Do they have the commodities? Are they trained? Do they have all that? And that would then inform an intervention that we're doing to test this multi-level integration. We're working with the National Immunization Program on all of this. And the goal is that once we are able to lay out how we can do the integration on the different platforms, nutrition have their own platform, immunization have their own platform. How can you do it? That can then inform our effort to, develop the roadmap, and hopefully that can then lead into a policy. But we have to know that there is already there's a long-standing policy to integrate vitamin A, for example, into immunization program, and then as we said, in some health facilities, integration is happening. But what we want to see is a systematic investment in integration and ensuring that it is tracked. Because what you don't measure, you cannot you cannot promote. I'm pretty sure I said that statement wrong, but the point is that we need to have measures for integration so we know when we're doing well on it and when we're not. So the hope is that this roadmap is going to lead and help drive the policy for it.
Great, thank you. We have time for maybe 1 or 2 more. So the next question came from Joseph, and he asks, could you please expand on the stunting and wasting prioritization?
Yes, I know that looks a bit odd. You have 44% stunted and 9% wasted, and then we're focusing on wasting. Well, the thing with wasting is that it's a condition where there is an acute condition that is amenable to intervention. And if you think about immunization interventions, when you have access to kids, you can provide nutritional supplements that address wasting. Stunting is a more system-wide, intervention that is required. And I'm glad that Habtamu is here, so perhaps he can he can answer that question in more details. Thank you.
Thank you, Joseph. Yeah, I think we deliberately selected wasting because one, it's unable to intervention. Two, the way the health system respond to both immunization and wasting, I think that would be a good point of integration. But stunting, as you know, the cause are multifactorial. It can be health system issues or it can be other non-health system issues. So we thought it will be it was multifactorial and it's system. Most of the issues can be beyond the health system, the health system and the health sector. That's why we have prioritized wasting over stunting, but it's not in any way undermining the importance of stunting.
Thank you, Avtamu. So we need to move into the breakout rooms. I just want to say thank you again for all of the really important questions. I know we didn't have time to get to all of them, but I'd encourage Avtamu and Chizoba to continue to read the chat and try to respond to them directly. So next slide. Now we're going to move into our breakout rooms, which is always the most exciting part of our meetings. Now's the opportunity to really dig in and discuss with each other and sort of get into the weeds in some of this. Next slide, please. So you have the chance to choose your own breakout room based on the discussion question that you are most interested in. So we have 6 breakout rooms. We have 1 breakout room for Spanish speakers and 1 breakout room for French speakers. And those breakout rooms will be moderated in that language. And for the Anglophones, you can choose between question 1 or question 2. So question 1 is, how can FP services feasibly and effectively contribute to MIYCN and increase childhood vaccination rates, particularly during the preconception and postpartum period? If you're interested in discussing question 1, you can join breakout group number 2 or number 3. If you're interested in discussing question number 2, which is what can be done during ANC to increase childhood vaccination rates and postpartum family planning rates, please join breakout group number 4 or number 5. And for our French and Spanish speakers, you have the opportunity to actually discuss both of these questions. So you don't have to choose, and hopefully you'll have time to get to both of those. So next slide, please. So right now, please select a breakout room to join at the bottom of your screen based on the question that you're interested in discussing or the language, either French or Spanish, if you want that discussion moderated in that language. And we will have about 30 minutes for discussion. We encourage everyone to turn on their cameras. If you can, your moderator may ask you to turn them off if we're having bandwidth issues. And please have fun discussing and introduce yourselves again, maybe when you come off mute to add to the discussion. And we will come back to plenary before the meeting closes today. So right now, please choose your breakout room, and we look forward to seeing you there. And if you have any technology issues, you can also add that to the chat, and Shantae can help you get to the breakout room of your choosing. Welcome back. Always hate to stop discussion, which I'm sure was very interesting and engaging. As folks continue to join us back in plenary, I'd like to spend a few minutes hearing from each of our moderators. One key takeaway or one point that really was sort of discussed in your group or was really sort of took off in the discussion. So I'm just going to go down my list. So Peggy, I'm going to start with you as one of our moderators for question 1. What was sort of a key takeaway or something that really stood out in your discussion group? Peggy, you're on mute, so unfortunately we can't hear you. There we go.
Sorry about that. We had a great discussion. Unfortunately, ran out of time, but certainly a lot of enthusiasm about the importance of the integration of services. There was some enthusiasm around the importance of LAM and being able to promote LAM as a family planning method, especially in settings where family planning is taboo or is restricted, interventions around family planning, that's been a real opportunity. And then there was an interesting question about financing models and whether I'll just a great interest expressed by Caitlin Bryan about identifying financial models and how if there are any out there that could be studied and used, because it's such a critical barrier to our integrated services. So thank you.
Thank you, Peggy. Adriana, what was maybe one key takeaway or something, that really sort of took off in your discussion group?
Yeah, sure. I think we had a couple of things that came up a few times in different ways. So one was kind of more around the health workers and workforce and thinking about orientation and training and how critical this idea of making adjustments to workflows to enable integration is really critical. I think that came out in a couple of different ways. And then I think another thing that came out in a couple of different examples was this idea about the quality and experience of care and how, whether you're building trust with and relationships with engaging men or with first-time parents, how building that kind of positive experience of care can affect and later care seeking, which we want to see with improved immunization rates, postpartum family planning, etc. So
thanks, Adriana.
There was a lot, but I'll stop.
Thank you. On, please share.
Yeah, we ended up speaking more about question number 2 than 1, but I think one of and we covered a lot of different countries from Madagascar to South Sudan to Niger, and I think the common thread was the sort of severe lack of human resources, especially at the sort of most rural areas where perhaps, at least according to Chizoba's presentation, the problem of zero dose and nutrition may be the highest, that the sort of shortage of human resources being very severe. I think our takeaway was we really need to think about community engagement, the role of community health workers, or even care groups was a model that we said that we think is really promising for integrating nutrition as well as family planning and sort of encouraging care seeking for prenatal care, which then leads to other services. And then I think there was also an interesting discussion about gender norms and the fact that we have to recognize that especially in the early postpartum with a young infant, it's sometimes very hard for women to access services. And so having a broader perspective and sort of task sharing community health workers to look at the whole family and not just the individual woman was important. So
Great. Thanks, An. Very quickly, Brooke, what was one key takeaway or one highlight from your discussion?
Yeah, thanks very much. And we talked about some similar topics, especially around gender and also expanding the workforce that would be involved in integration. And we also kind of touched on some of the data and the integrated approaches to be able to monitor and follow up families.
Great, thank you, Brooke. And Hubtamu, just one key takeaway or discussion point that really stood out.
I think our group, one is a good experience shared from Nepal, how to leverage immunization service for family planning. I think that was a good takeaway. And also, I think another good takeaway is about multitasking by health provider to provide social services. Experience from Guatemala was shared. But an interesting discussion we had is about how much time would this integration save and how it affects also the quality of counseling when you integrate different services. So that was an interesting takeaway from our discussion. Thank you.
Thank you. And I wish we had time to really hear from all of the groups in depth. One of the things that we will do is actually try to summarize everything that was shared in the discussion groups, and we will share a meeting summary document after this meeting. So we look forward to sharing that, and hopefully we've been able to capture all of this rich discussion from the discussion groups, and we hope to share that back with you. In the spirit of that, next slide, please. We're in our last few minutes together. We're excited to share a few ways that we want to connect with you between global meetings. As I mentioned at the beginning of this meeting, this community of practice hosts 2 global meetings a year. This being our first in 2024, but we really miss engaging with you all between those global meetings. And so one way that we want to start doing that is our brand new LinkedIn group for this community of practice, which we're very excited about. You can join us on LinkedIn after a few quick steps. So the first is to make sure that you're signed up for our COP in general. Many of you probably received this invitation in various ways, but the first step is to sign up for the COP. You can see the link in the chat. And then after you sign up for the COP, we will share the link to join our LinkedIn group. This LinkedIn group is a private group, and we really hope to use this LinkedIn group for you all to communicate with each other, to continue discussions with presenters, to continue communicating about sort of what we were discussing today. And so please do join the COP and join our LinkedIn group. And then we will also share the meeting summary there as well. And then lastly, we always love to hear from you, your feedback on these meetings. Next slide, please. So if you can please use your phone to scan the QR code, or we will also share this link in the chat. And we'd love to hear your feedback on today. And there's also a question around other topics that you would love to hear about. We take the survey seriously, and you all have made a lot of really interesting recommendations on what you want to hear in these meetings, and we really plan around that. So we are at time, so I will leave it there. We will follow up via email. Please join our COP, and please join us on LinkedIn. Thank you again to Chizoba for a wonderful presentation. Thank you to our moderators and note takers for facilitating rich discussions, and we will be in touch very soon. So thank you so much, and have a great rest of your day and evening. On behalf of the MIYCN-FP-Immunization COP. Thank you all.
Okay. All right, Lindsay, we might just want to hold the Zoom open just to make sure everyone gets the link to the server.
Yeah.
No worries. Down.
Thank you, Lindsay.
Thank you, everyone. Merci à tous mes amis francophones. Bye.
Thank you.